My name is Dr. Mohini Parmar. Postal address is Percival House, Uxbridge Road, Ealing, London. I am a part-time senior partner at Barnabas Medical Centre in Ealing, and I'm also chair of Ealing Clinical Commissioning Group.
Could I ask you please to turn to volume 2 and to page 591 to 598?
551.
591 to 598. Can you confirm that that's your submission and you wish it to stand as your evidence to the Commission?
It is indeed.
Can I ask first of all about what you say about the specific needs of the Ealing population? Now, it's growing rapidly, that's correct, isn't it?
At the moment, the ONS figures have said that there is an element of growth, but not that we know how much the growth is going to be. At the moment, the ONS figures have not shown, from the figures that we've got, that there is growth, but we do know that there are some developments going on in the Ealing borough.
Can I ask you to have a look, in front of you also see volume 1. Can I just ask you to have a look at page 74 in volume 1? And what this is the submission that was provided by the London Borough of Ealing. And I just want to take you to what they say about population forecasts and ask about your views on that. Do you have it in front of you?
I do indeed.
So it says Ealing's population, as per the latest statistics, is estimated at 342,500. The borough's population is forecast to grow by over 400,000 by 2031. These figures are significantly higher than those referenced in the SAF business case. Can I invite you to comment on that, please?
I'm aware of this discrepancy on the ONS numbers. I'm also aware of the numbers around 400,000, because we also know in the GP registered list we operate to a working number of around 390,000.
If the figures are an underestimate, doesn't that have a significant impact on the projections of what services will be required?
The services that we are planning and budgeting for within our out-of-hospital services relate to the GP registered list, so closer to the numbers that have been submitted by the London Borough of Ealing.
So you're saying that the SAP proposals are based on GP figures and not the ONS figures?
What I'm saying is that Ealing CCG, when it plans for its out-of-hospital services, when it plans for the services going to commission from hospital, is working on the GP registered list.
If that's not correct, if it's an underestimate, does that cause a problem?
The GP registered list is perhaps one of the most accurate numbers we have. We know that we have a certain element in London of an unregistered population, and we cater for that, but the GP registered list we've always had this discrepancy. This is not new.
And what about hard to reach populations which aren't on the GP's list? How does that figure in the population estimate?
It absolutely figures. We are well aware of the wards and the particular GP lists and the particular parts of Ealing where we know we have hard to reach groups and the services that are, and the special care that we need to take to commission the services from there and to ease the access for those residents.
So are you confident that the population projections are accurate?
I would say that the planning assumptions that we are putting in place for out-of-hospital services to ensure that access to all Ealing residents is uniform is based on the GP registered list and on the patient flows, the demographics, taking into account deprivation.
And just thinking about some of the groups, am I right that the most sort of high index of deprivation in the area is concentrated around the Southall, Northolt, Greenford and East Acton areas?
Yes, there's Dormerswell, Southall, Greenford and East Acton, yes.
So those are the groups that you particularly want to reach in terms of provision of high quality accessible services, is that right?
My responsibility as Ealing CCG Chair is to commission services for the entire population of Ealing and take special account of those groups for whom it is not as easy to access NHS services.
And aren't those the very populations whose natural hospital is currently Ealing?
Again, I will come back to say that my responsibility is to commission services where they are, and to commission the services that are delivered to the high quality standards for which I would expect every Ealing resident to have access to. It is on the basis of quality that I would determine where the service is to be commissioned. The second point it is then the responsibility for us to make it easy for people to access those services as closer to home as it is possible to do so, and in the right place when it is right for that to happen.
I understand that. I was just asking whether at the moment you agreed with me that the natural hospital for those populations to gravitate towards is the current Ealing Hospital.
Ealing Hospital has been in Ealing since 1970. It is well established. It has served Ealing population and it continues to serve Ealing population extremely well. But what I come back to again is about us commissioning for the high clinical quality standards and the ability of us as an NHS to be able to provide that equally for all residents.
If the function of Ealing Hospital changes, though, will it have a significant effect on those populations?
When we commission services, plan them and mobilise them, we will do it on the principles, and we've talked about these three principles, which is to localise care wherever and whenever it's possible to do so as closer to a person's home, to centralise when it is right to do so, and more than anything else, to work with our social care colleagues and the voluntary sector to integrate it across the system. And this is absolutely in response and planning for the changing needs of our population.
So, am I right that you would only endorse changes to hospital services if you felt confident that the alternative out-of-hospital services were able to ensure that the quality of healthcare wouldn't be diminished?
Absolutely. There is absolutely no doubt in my mind that the quality of services we deliver in acute, out of hospital and primary care needs to be delivered to the equal quality standards. We cannot accept anything less than that.
And is it equal quality, or are those changes only to be endorsed if they will deliver a better service?
We will, when we commission services, set a quality standards which will allow the individual to have an integrated pathway across the system, considering, as far as the patient is concerned, the quality of care that is offered to them from their GP, from a community service, from an intermediate care service and an acute service should serve their needs.
So it's not just exchanging like for like, that's what I'm asking. Is it just exchanging like for like, or are you driven by the idea that the services you are seeking to provide must be better?
Not only better, but they should be more appropriate for the person's clinical need. So when it is absolutely appropriate for the individual to have their care in an out-of-hospital setting, because we know now with the changing demographics, with people with long-term conditions, with people with cancer living for longer, which is all a good thing, with integrating services, to be able to offer that composite of service closer to a person, so when it is appropriate to do so and right to do so and clinically right and gives us better outcomes, then absolutely yes, because that's what I would want for me and my family as well.
Isn't that just a different way of saying better?
Yes.
Yeah.
Good.
Can I ask you just to look, please, at volume 5, which is one of the volumes in front of you?
Yeah.
And it's the first document in there. And if I could ask you, please, to look at page 1544. Now, what this is, it's a submission by a gentleman called Dr. Thomas Rosenbaum, who is a consultant urologist at Ealing Hospital. And I just want to invite you to comment on what he says. On the bottom paragraph of 154, he says, Ealing Hospital is located in a strategically perfect place. It is radially easily accessible from Southall and Ealing. It has excellent public transport access, mainly radially along the Hillingham Road, and crucially only 150 metres away from the about to be developed Hanwell Cross rail station. Do you agree?
The Ealing Hospital site and the service and on that Ealing is, yes, it's got very good access to public transport. Yes, it is very well located.
And then what he goes on to say, and it's at the top of that page, is by contrast in relation to Northwick Park Hospital, and West Middlesex. He says they're very poor communication, very poor transport links. Now again, is that correct?
I wouldn't say that West Middlesex and Northwick Park do not have good transport links. Northwick Park has an underground station next to it, and it has good transport links, just as Ealing does.
Is it as easy to get from Southall to Northwick Park Hospital as it is to get from Southall to Ealing Hospital?
From Southall it is probably easier to get to Hillingdon or West Middlesex Hospital or take the train to St Mary's than it is to get to Northwick Park, and I would expect, yes, you're crossing two roads.
Right,
yes.
well, let me reframe it. Is it easier to get to Ealing than it is to get to any of the other hospitals, which are don't just say as major hospitals?
Ealing Hospital is located in Southall, so for obvious reasons it is within the geography of Southall.
So at a very basic level, when the transformations that you're talking about mean that people who do need hospital services, appreciate that part of the driver is to take them out of hospital, the people who do need hospital services, which are currently provided at Ealing, they're going to have to travel further, aren't they?
The services that are provided on the Ealing Hospital side, the services that all of us get as NHS, most of them are provided in an outpatient diagnostic setting, and I would expect all those services to be continued to be delivered on the Ealing Hospital side. Now that we've got a merger with Northwick Park and Ealing, it is actually easier to be able to support the delivery of all those outpatient services, whether it's renal dialysis, whether it's outpatient, whether it's diagnostics, whether it's day case surgery on the Ealing Hospital side. What is also true further on to add is that for patients who do require interventions for which we know specialist expertise and technical expertise with the new technological advances, in asking them to travel to a place where they get the best clinical care to improve the outcomes for their clinical case is the right clinical thing to do.
But the question I was asking, I appreciate that you're answering a slightly different subject. The question I was asking is, won't they have to travel further if they've got to go to hospital? Regardless of the clinical superbness of that hospital, won't they still have to travel further and have longer, more expensive journeys?
The balance of being able to provide a service for the right clinical outcomes and having to travel slightly further, all the evidence is that to get the better outcomes mitigates some of the inconvenience of having to travel more. But again, coming back, it comes back to the point where actually 80 to 90% of the activity will be delivered locally, because that is the right thing for the patient.
When you say it will be delivered locally, do you mean on the Ealing Hospital site still?
On a combination, as it is currently happens in the Ealing Hospital site, in the other community hubs in Ealing, but within Ealing Borough.
I just want to tease this out just a little bit more, just in terms of the transport links. Could I ask you please to have a look at volume 5, page 1745?
Sorry, 1745.
1745. And this is a submission from a gentleman called Dr. Stahoka, who I'm sure you know because he's a fellow Ealing GP, and he's also a member of the Greater London Assembly.
Yes, I do know him, yeah.
And what he says in his paragraph 4 is this, is South have failed to take into account the impact of the local population, the impact on the local population. West London has pockets that are the most socially deprived in the country. Southall is particularly deprived. And then what he goes on to talk about, paragraph 7, is this: I'm concerned that the increased travel times for patients as a result of the A&E closures. If a patient lives in Southall or Hanwell and needs to get to Northwick Park, it will take about an hour and 40 minutes on the bus. Are you confident that that isn't something that's going to cause difficulties?
In the SHAF proposals, we said we would have 5 major hospitals. The 5 major hospitals are St Mary's, Northwick Park, West Middlesex, Hillingdon, and Chelsea Westminster. Patients from Southall could travel to any of these hospitals, and that's what it will be. And the evidence that we've had in terms of travel times, in terms of blue light ambulances, is there in the SHAF business case, which says there is a very marginal, for blue light ambulances there is no difference. What we do know is that for people, for carers, there is a slight increase, but that's where we are with the travel times.
So, two experienced practitioners, one based in Ealing Hospital, a consultant, and another a GP with a wide-ranging practice in the area. Are they both wrong to be worried?
I think the concerns are valid and right, and I think it is our responsibility to address the concerns. We also know that on the Ealing Hospital side, in the SHAF proposals, whether it's urgent care centres, and we don't know what the A&E changes are going to, because we're waiting for the Bruce Keogh's report to come through at this point. So some of these things are still to be determined.
So are they wrong to be worried?
I don't think it is right, Mr. Durant. It is quite right for people to be concerned, to address those concerns, and it's our responsibility to address them and communicate our responses and deal with them.
Now, thinking about the plans for Ealing Hospital, we've talked about this a bit, but can you assist the Commission with what services will definitely remain at that site once it becomes a local hospital?
The services, the plans that are in the outline business case, which have been jointly developed by Ealing CCG, we had 3 or 4 public consultation and a road shows where we talked about it, and along with Northwick Park and London North West, as you know, it's now a merged organisation. The services which will stay on site would be a 24/7 urgent care centre, which would then be enhanced to the new London and North West London specifications. We would have full outpatients facilities, full diagnostic facilities, renal dialysis, more fields on site. We would also have day case, and we would also have beds on site, inpatient beds on site.
Do you know how many inpatient beds?
That is still being worked through at this point. The numbers that have been around in the public domain are something between 70 and 100.
Do you know when that will be decided?
As the clinical model of care has been worked through to a degree with the consultants, as Dr. Spencer mentioned earlier. The outline business case is currently being discussed with the Department of Health and NHS England at this point.
So in terms of whether you know when that's going to be decided, is that a no? We don't know.
Indeed, no.
Can I ask you about the plans for the closure of the A&E department at Ealing Hospital? Now, you've just said it's going to have an urgent care centre. And what you describe that as in your document that you produced, and it's at page 596, is a local A&E and GP-led urgent care centre.
So would you remind me which
Volume 2.
Volume 2.
Page 596. This is your submission to the Commission. Top of the page, first paragraph. Can you see that?
Yeah.
What I wanted to ask you about is this: what's a local A&E?
So, what is clear is that we know that there are no planned changes to A&E at this point, and we are all waiting for Professor Bruce Keogh's report to come through, which is being discussed nationally at a national level. And when the report comes through, clearly we will look at those and comply with all the requirements of that report and how we deliver services for within North West London.
So does that mean that you don't actually know what a local A&E will be composed of at the moment?
I think that is correct, yes.
Do you know, for example, you may simply not know, will it be able to take blue light emergencies?
I don't know. We're going to wait for Bruce Keogh to give us his full report.
And do we know when Bruce Keogh's report is going to be available? I know that's not equal to me.
Yeah, apologies, I don't.
So assuming that local A&E is in some way different from the current A&E, because otherwise there'd be no point in this exercise at all, what will happen to users, service users and patients who require full A&E? Where will they go?
We know that to improve outcomes for patients, if we have what we call a full A&E, it is co-located with surgery, it is co-located with other units, so that patients have the full senior clinical input, and more than that, the technological support in terms of radiology, in terms of intervention radiology, to give them the best outcomes. So we know that the big A&Es. In Shaft, we've got a proposal for 5 major hospitals, but as I said, what is going to happen to a local A&E, we'll wait and see what Bruce Keogh's report comes through.
So we don't know what the local A&E is going to be composed of?
Yes, as I said, we're waiting for some of the clinical guidance and the evidence to come through, and as in anything in medicine, things change and we will respond to it.
But we do know that there isn't going to be a full traditional A&E at Ealing Hospital anywhere.
There are no plans for any A&E changes, as we've said, so for the next 3 years.
When this service comes on stream, will it be GP-led or consultant-led?
Once again, once we get the clinical model of care, we'll work through what is the right clinical expertise. The GPs will always be working in urgent care centres. They work as a combination. What we've also done in Ealing at the moment is GPs are providing extended hours over the weekend. So the range of services that we're trying to provide in an out of hospital settings continues to increase. A lot of people who go to urgent care centres, we know it is need for primary care, and the right place for those patients to be seen is by a GP.
Can I ask you then, I don't know whether from your previous answer you're going to be able to answer this, what you also say in that same page, and it's in the second section, is that urgent care centres will be the first point of access. And then you go on to say, the urgent care centres at Hammersmith Hospital and Central Middlesex Hospital now offer an enhanced specification to widen the range of conditions treatable. This ensures that Ealing patients accessing care at these sites are able to access services at urgent care centres which would require accident and emergency access in other parts of London and England. What services does an enhanced urgent care centre provide? So what are the A&E services that it will provide that a normal urgent care centre will? So
some of the stuff is around to paediatrics. In terms of having additional paediatric support on site, and it is also to do with the access to radiology investigations. So when Ealing's Urgent Care Centre was commissioned 3-4 years, our specifications were already of a higher standard, but we are reviewing them at this point, and we'll be, over the next year, our urgent care specification will be completely in line with those of Central Middlesex and Hammersmith. But as I said before, they were already commissioned to a higher standard.
What Dr. Sahoti says, and I'll take you to it if needed to, but basically he says, and this is for your reference, it's a volume 5, 1745, 28,000 patients a year transfer to Ealing Hospital UCC as it currently stands, to Ealing Hospital A&E. Now those departments are both on the same site. Mm-hmm. And what he expresses is concern about the risks if the two are no longer co-located. Does he have a point?
There are examples of urgent care centres up and down the country which are not co-located with an A&E. Hemel Hempstead is one of them. There are examples when we do have, if for those services where those areas where urgent care centres are not co-located, there is a proper clear pathway in place. Those are networked with major A&Es. There are clear pathways in place with local ambulance services to ensure that patient safety and quality is not compromised.
Can I ask you just to have a look at volume 4, please? It's page 1421. What I'm going to take you to is a very short submission by somebody we're going to hear from later. Volume 4.
Page
1421.
This goes up to 131, 1421. Yeah.
And this is a short submission from a member of the public. And what she sets out in this is an incident that she says occurred with a neighbour of hers. And what she describes is this, and I'll read it very briefly. One of my neighbours was taken ill. His brother, knowing the ambulance service was very busy, took him to CMH in a cab. In the urgent care centre, his condition worsened and he collapsed. The staff at the UCC had neither the right equipment nor the specialist knowledge to revive him, so they called an ambulance. By the time he was revived, he had not been breathing for 15 minutes and suffered brain damage, and he died in hospital 2 weeks later. What I want to do is to invite you to comment on whether you think there is a risk in non-co-located A&Es and UCCs in the light of that anecdotal evidence.
Obviously, I cannot comment on this because I don't have any details on this, but I think what I will come back to saying again is that there are examples up and down the country where we have got urgent care centres which are not co-located with A&Es. It is our responsibility when we do commission those urgent care centres that they are properly networked with a major A&E, that we have very, very clear clinical pathways in place which are agreed with the hospitals, with London Ambulance Service, and that these pathways and these processes are clearly owned and vigorously tested by the clinical and operational teams.
So, as you say in your statement about vision, services need to be easy to use and well understood by users, don't
Correct.
they?
Absolutely.
Isn't there a risk that people, particularly from non-English speaking communities, simply aren't going to understand the difference?
I completely recognise that risk, and I think it is our responsibility to spend time not just with in different methods of communication, because all of us learn and absorb information differently, to ensure that people understand what is the best way to access services for them.
Do you think you've been successful in doing that?
We have been successful in some parts. I will completely acknowledge that we could do more.
And just thinking about, we talk about the time for closures, and I think you've said nothing will happen for 3 years. Can you be more precise about the time frame?
As I said, what I can say is there is no planned changes for the next 3 years. I cannot comment beyond that.
Do you think the uncertainty, what effect do you think that uncertainty has on public confidence?
Any uncertainty creates an element of anxiety, and I recognise that. But I can say categorically, and I've said this publicly, there are no changes for the next 3 years.
Now, thinking about the out-of-hospital services, they're still at a fairly early stage, aren't they, of development?
Our out-of-hospital strategy is clear. It is. We've shared this with our Health and Wellbeing Board, with our scrutiny. It is in its early stages of implementation, but it is a clear plan across the health economy.
It's a pretty Herculean task, isn't it?
It is what is the right thing to have done, irrespective of anything else.
I don't know whether you can answer this or not, but given what we hear about the tightness of funds and the need to spend public money wisely, what's your take on spending 13 million on consultancy fees in 10 months?
I'm not going to comment on that. I think you need to really talk to the finance director, please. Thank you.
Now, you're clear that your CCG wanted to keep Ealing Hospital as a major hospital, but ultimately you chose to support the changes. That's right, isn't it?
My letter at the JCPCT was very clear in what our preferred option was and what we were absolutely going to go forward with.
Does that ultimately suggest that there was a lot of discussion and perhaps dissent about this issue?
I think it is fair to say, and and I've been to many public meetings and I've met many people before, that people clearly have anxieties and concerns.
No, I meant within the CCG. Because ultimately you said you took a decision to support. I wondered what the thinking process to get to that was.
We're GPs. We've lived in Ealing. Most of us live and work around the area. We are going to have concerns, but eventually we have to make the decision on the clinical evidence that it provides and what is the right thing to do.
So can I just ask you hypothetically, if the SAF programme was reviewed and a decision was taken actually to keep Ealing as a major hospital, would your position then be that that's clinically unsafe and shouldn't be done?
What was true that the SHAF programme looked at how we were going to deliver services across a health economy around a population of 2 million and how the services are going to be configured. The plans that were put forward allowed the best opportunity for that to happen. Ealing residents use every hospital in North West London. We are absolutely unique. We use every hospital in North West London. 60% of Ealing women choose to deliver outside. What I spend in Imperial is equivalent to the same amount of money I spend in Ealing Hospital.
If SAS turned around and said you can keep Ealing Hospital as a major hospital, would you say to them, no, that's not a good idea?
The option of keeping Ealing Hospital as a major hospital, if it if it was part of the way, if you could deliver it, we're talking in a hypothetical situation. It's hypothetical. If you have a blank piece of paper, who knows? But
hypothetically, as an Ealing GP, would it have been your first preference for Ealing to have that as a site of a major hospital?
If you had a complete blank piece of paper, and yes, you had a hospital in North West London that catered to all the residents of North West London, was able to provide care and provided even easier access for Ealing residents, of course.
Can I ask you about the maternity service?
Yes, of course.
Now, we heard on one of the previous occasions from one of the midwives, and what she told the Commission was about the modern birthing facility that had been open there for only a few years, and she talked about the changes and improvements she'd seen in local women, particularly from BME communities, accessing services and becoming more open to new ways of thinking about birthing plans and taking a more empowered role. And she was very positive about that. And we also heard from Dr. Lowry, who was a retired endocrinologist, and she spoke about the needs of women who had gestational diabetes. And what both were talking about was the particular expertise that had built up linking the populations that are using Ealing maternity and the staff that were working in Ealing maternity. Both of them were very worried about that particular expertise becoming dispersed and therefore lost. Can I invite you to comment on those views, please?
Absolutely. Ealing maternity has provided a service to women. The changes that we are proposing will retain the ability and enhance the ability for the care, the community model of care for women who've got diabetes, for women, for the medium and intermediate risk pregnancies in Ealing, within the Ealing borough, and some of them on the Ealing hospital site itself. So I don't see that clinical expertise being dispersed. What I see is that clinical expertise being integrated and linked across both the primary, the midwifery and the acute sector, so that the woman actually gets a continuity of care.
So you don't share those concerns?
I would say that the community model of care and the model of care that we have designed will enhance the clinical care that she would receive.
In terms of the actual decision-making process about the closure, now in February, when you prepared your submission, what you said was that changes have been accelerated as a result of concerns about future sustainability given the falling number of bookings. I just wanted to ask you this, isn't it something of a self-fulfilling prophecy that if you say someone's going to shut, people won't look into it, particularly with something which is so time-sensitive as a pregnancy?
I can understand that hypothesis, but what is also evidence is that Ealing maternity was always historically has been a very small maternity unit, one of the smallest in London. The numbers have been declining, the number of births across North West London have been declining, and in Ealing they have declined further than in any other unit across North West London. It was then became clear that we could see that rate of decline. It was our responsibility then to plan for when that closure would happen, and in that planning to ensure that we have both the physical capacity and the workforce in the right place at the right time, and that it was tested before we had to make a decision on the date of closure.
Do you know when the decision is going to be made?
Ealing CCG has a governing body in a couple of weeks' time, and we will be looking at the evidence at the time.
Is that going to be a meeting at which a decision will be made, or is it a discussion meeting?
I can say at this point that it is a meeting we will be having in public. That's all I can say right now.
Just finally, last thing I want to ask on this, and indeed any subject, is you've provided a further document, and it was an email which was sent by Andrew Piper on your behalf about the delay in closure. And what you say is that Ealing Hospital is currently a safe place to give birth, but we know that in future Ealing may struggle to meet those standards. First of all, can you explain what you mean by that? And second, can you tell us what the evidence of the prediction of future risk is based on?
Yes, of course. We know that and this is clearly across been seconded by the Royal College of Obstetricians, that to deliver the best quality outcomes for women, we need to have increased clinical and consultant input, for which we require 168 hours of consultant cover and 1:30 midwife ratio. We also know that because that the other hospitals in North West London have been investing in their workforce and provide much more consultant hours in labour ward. Ealing only provides 60 hours of consultant cover. This will inevitably lead to an unequal service for Ealing women. It's my responsibility as Ealing CCG chair to ensure that all women in Ealing get the same quality of care. For example, West Middlesex already provides 140 hours, and after the changes it'll go right up to near 160. Northwick Park already does 98 hours. Queen Charlotte's already does 98 hours. It's about having the same access of quality care for all Ealing residents.
But it's currently safe on 60 hours, is that right?
The services being provided on the Ealing Hospital site are clinically safe.
Thank you. I have no further questions. I should apologise. I'm slightly over on my time.
Thank you.
No, I think we'll be okay from the indications I got from Dr. Hurst and Dr. Lister. Dr. Hurst, if you would go first.
Thanks so much. So it's rested and explored most Ms. Weston has explored most of my concerns. I can only ask this: I have been given the impression that many residents feel that they're the cannon fodder of this process. The Ealing residents are cannon fodder, and they, as much as I respect the need to improve the out-of-hospital services. And many of those services that have been suggested are already established in other areas, in Hammersmith, for example, and so on. And these are very, very good. I'm not sure how relevant they are to SHAP, but just to do with good practice. Now, nevertheless, and I speak as an Ealing resident as well, secondary care is the major focus, the major concerns. And I just need to ask you, as I suppose I tried to ask Dr. Spencer, this paradox that those who are most deprived and the poorest are having to travel the furthest. And I know you've made light of it, but we've had evidence that this is not the case, that the travel issue is great, are having to go the furthest and use the most money for their secondary care. And that those who are most privileged don't. It's the opposite way around. In other words, you've mentioned the train service from St Mary's to Ealing, but the service goes in both directions. So, I thought, which I won't go on too much about, but putting that in case, seeing that as an Ealing resident, and you as the chairman of the CCG, which represents Ealing, perhaps it's your role to look for that blank page and maybe fight for Ealing to have a major hospital.
Okay, so that's an interesting question. I would say my role as Ealing CCG is to commission the best services for Ealing residents. One of the things, it's quite an interesting paradox that, or what you suggested is that if somebody is from a deprived community, the best care should be through a secondary care sector. I would submit to you that actually the more difficult it is for people to access services, the more deprived. It is our responsibility to provide the care closer to the patient's home, make it easier for them to access primary care, make them easier to access care for long-term conditions, and actually provide an integrated health and social care model. Because, and I know, for a lot of these people, the difficulty is...
I'm asking about secondary care. I accept all of that. We all accept that. But when it comes, people are concerned, people approach me in Rangam, they are concerned about their secondary care and where it's located. We accept and take as read all you've said. And as a practicing GP, that's what I worked for all my life. But where secondary care is necessary, isn't it your role as a chairman of Ealing CCG to perhaps fight, or I don't know what verb to use, what word to use, to so that Ealing residents, who are the most deprived, have the same privileges as those who are not
Absolutely. So I would agree with you entirely. So I would say, and if you take just secondary care, I would expect the same access and the same quality of care, of secondary care, for everybody.
But that's not the case, is it?
So, and therefore, I would say, so large proportion of Ealing residents go to Imperial, some proportion go to Chelsea Westminster. When we do elective care, we choose as GPs to refer for where we get the best clinical outcomes. So a lot of my paediatric surgery, I refer to Chelsea Westminster, quite rightfully so.
Why not Chelsea and Westminster come to Ealing then?
If you can get them all to move, maybe. But that's.
Why couldn't you fight for that?
It's a
hospitals do move, don't they?
Yes, hospitals do move, but the question is also services can move. So now that we've got Northwick Park and Ealing Merged Trust, and Northwick Park is a regional centre for MaxFax, you've got St Mark's there. For Ealing residents, we have a real opportunity to be able to provide access to surgery, to access to these services on the site. Northwick is also a regional centre for vascular surgery. So actually that allows that to happen.
Thank you. Forgive me, just one more point. I just want to understand how much you feel you've taken the residents and your clinical colleagues with you. I mean, you quote on page 594 the questions that you asked. 3 statements, do you agree or disagree that there are convincing reasons? The 3 bullet points you raised, the new standards, that we shall have new standards for care in hospital, etc., delivering some services, etc. Forgive me, but that's a mother and apple pie statement, isn't it? You know, we would all agree to that. Mm-hmm. How much have you carried Ealing GPs with you then?
So when we went through the decision making, Ealing, it was absolutely clear that for Ealing, the fact is there, if you're going to make change of that dimension, people are going to be concerned, and quite rightfully so.
How do you carry the Ealing GPs with you?
I'm trying to explain. We did exactly that. We had 3-4 meetings with Ealing GPs where we had an open discussion. We had people coming to talk to us. We let discussion, so we went through, and then Ealing CCG was the only CCG which actually went through a formal voting process, because it was absolutely clear that we needed to work with our colleagues, and you've got the results of that vote. Since then, at every council of members meeting, we discussed the proposals in small groups as a larger meeting, so people are fully aware of what is happening.
They're aware, but do you think they agree with it?
Like in any other profession, there will be some people who will agree and some who will not.
I still don't know whether the majority, you have the majority with you or not.
You have the vote from then. I am at the council of members.
That's what I call the mother and apple pie statement. You know,
we are where we are. There's, as I said, some people will agree, some won't. It is my responsibility to continue to give the clinical evidence and the case and demonstrate what we are doing to deliver out of hospital services and to commission acute hospital services in line with clinical evidence.
Thank you.
Thank you.
Dr. Parmar, just a couple of points. You say the A&E is not going to close for 3 years, and you said it several times. How can you be sure of that? Because if you announce the A&E is going to close, and we now have a timescale that is starting to tick down towards the 3 years or whatever it might be, if you're a consultant or you're an A&E professional, are you going to apply for a job at a unit you know is going to close a couple of years down the line? I mean, aren't we going to create the same kind of scenario we've seen with the midwifery, with the maternity services, where it's difficult to recruit staff because the service is seen as blighted? So you can't really guarantee, can you, that it will be 3 years?
Yes, we've said there'll be no changes, and we are now in a very privileged position in that Northwick Park and Ealing are now a merged organisation. So therefore we do have now a very large major hospital supporting and working with us to deliver emergency care on the Ealing Hospital site. And it's absolutely, I would expect to deliver that.
5 years ago, in South East London, there was a pledge to keep Queen Mary's Hospital open in Sidcup. And within 3 months, actually, in that particular case, the staffing problems were invoked as a reason for closing it down early. I mean, how can you guarantee that during the course of this 3 years that is not going to happen?
We can only go as far as long as we can only continue to provide services provided they're clinically safe to do so. If a clinical safety issue is, it would be my responsibility, like would be of any other clinician's responsibility, to make the right decision for patient safety and patient quality. That there can never be a carte blanche guarantee, but we have no plans to change A&E services. Clinical safety and quality of patient care is paramount.
And the other thing is you repeatedly said or admitted that you didn't actually know exactly what mix of services will be involved in this local A&E service. And obviously there's a wide range of parameters, because the use of the term A&E suggests a full-scale service with all the backup, whereas an urgent care centre is clearly a walk-in clinic with some professional staff available. And there's quite a big difference. But a local A&E is an ambiguous quantity. Now, if you don't know what that is now, how can you expect local people in Ealing to understand what that is, or to accept the idea that it's necessarily going to be as good as you're hinting it might be?
The whole issue around the emergency care pathway, local A&Es, the emergency pathway in primary, secondary care it's a national issue, and for London it is a unique issue. London is unique. There is now, Bruce Georg is looking at this. He's going to give us a report. We will have some clinical evidence, and we'll be guided and work with that to deliver what's the right service. I think it is fair to say that when the SHAF proposals happened, that was what the information we had. We will now have some additional information, and we'll make a decision on that.
I mean, the figure has been given of 28,000 transfers from the urgent care centre to A&E within Ealing Hospital. Now, that's clearly a way of working that has developed. People have become aware that if you go to the A&E and there's something more serious, it's not a problem, because you can be transferred quickly into the hospital. But 28,000 patients needing a transfer to a hospital which is several miles away is quite a logistical effort for London Ambulance Service. I mean, are you really thinking this through? Are you really ready for the scale of the problem that can be unleashed, even if these plans are implemented in the way you say?
I'm completely aware of the scale of the problem, and I am also going to go on to say that the changes will be made in line with clinical evidence, with full information, with consultation, with plans as and when they happen. I can say no more at this time, but I am absolutely aware of the scale of the change.
Just you say with consultation, with consultation with whom?
We have, when we worked through the proposals for our local hospital, we've been very open and transparent. We've had our meetings in Ealing Town Hall. We've invited members of the public. We are very fortunate in Ealing in having a very, very strong and engaged voluntary sector. We work very closely with London Borough of Ealing. We work very closely with the patient public. Our governing bodies are attended by members of the public. We will have an open and transparent process like we do.
There'll be a new public consultation on the new hospital?
I didn't say that we have a new public consultation. We always engage. We design services together. In all of the community services we've designed, we work with the members of the public, and they've been on our various steering groups, on our various committees on the design.
It's a conversation rather than a consultation.
What we need to do is to design services that makes it easy for people to use the services and to pick up where the difficulties are going to arise early.
Thank you.
Thank you.
Dr. Parmar, I just wanted to ask you a very short series of questions. And it's really returning to the topic that Dr. Hurst was asking you about the change in position, if I can use that word, that Ealing CCG took towards Ealing Hospital. Can I ask you to look at page 595 of the bundle, where your statement is set out?
Is that volume 2?
Yes. Not entirely, volume 2, yes. And it's the paragraph where you say at the top of the page, as a CCG, we expressed our preference to retain Ealing Hospital as a major hospital within any future configuration of health services in northwest London. First question is, what timescale are you talking about at that stage? So when was that your view?
So this letter was 2012.
So are you saying that you expressed your view in a letter in 2012?
So this was a letter to the JCPCT, if I remember correctly.
Right, and explain to me what the JCPCT is.
It's the joint committee of the Primary Care Trust where the decision for the shaft proposals was recommended.
And what was the basis in that letter for your preference that Ealing Hospital be retained? Hospital.
So Ealing CCG and Ealing Borough is a large borough. We've got a population of GP registered population for 390,000 patients. And it would be, if we had a blank sheet of paper, it would be very nice to have a very big hospital right in located somewhere that was very central. Possibly that would have been a blank sheet of paper, yes.
Well, let me just press you. I can't believe you wrote a letter saying it would be very nice to keep the hospital. What did you actually say? What are your reasons for preferring to keep the hospital?
It's about the question about access to clinical care. The question about delivering the clinical ones is never an issue. There's only the question about the location or the location of the estate, or the bricks and mortar of that. And yes, it would have been much easier to have said Ealing Hospital becomes, where we can provide all the services. But Ealing is a small district general hospital.
Well,
I think there is.
To come on, but you're making representations as part of Ealing, CCG.
Ealing's residents use all the hospitals in North West London, and I keep coming back to that. 34% of Ealing residents use Ealing Hospital, 70% use other hospitals. It is my responsibility to commission for all the residents of Ealing.
I understand that. I'm just trying to give you an opportunity of explaining what you did in between your initial view and the end. So the Joint Committee of Primary Care Trust, their response to you is what? When you say you prefer to keep Ealing Hospital in your letter?
So,
what did they say?
as you've seen the decision-making business case, there was a which was led by clinicians across the whole of North West London. It was then had an economic, a financial case, a commercial case, which was reviewed 3 times. And looking at all those parameters, a set of options was discussed and recommended.
Did you repeat your initial preference, or did you decide at that stage that looking at things in the round and taking into consideration residents outside Ealing, this was the best thing? How often, what I'm trying to get at is, how often did you express this preference, and how quickly did you change your mind and look at the bigger picture?
I was involved with the planning, and we were very clear right from the beginning what our preference was. It was also becoming clear that, again, I'm going to come back, 70% of Ealing residents, between 60 and 70%, use other hospitals. It is my responsibility to commission and ensure the care we get across for all Ealing residents. So there is always going to be, that has to be my responsibility.
And to be fair to you, I'm sure you would say that if you thought that there was a clinical disadvantage in the overall proposals, you would say so.
Absolutely. And we have made decisions on urology cancer at Ealing 3 years ago.
So putting it all in the round, do you accept that you didn't fight for your initial preference because you looked at it in the round and decided that you felt that looking at everyone's interests, including those outside Ealing, this was the best way forward?
No, I come back to it and say my responsibility is to commission for all Ealing residents. 60 to 65% of Ealing patients use other hospitals other than Ealing Hospital.
Thank you very much.
Thank you.
Thank you very much for attending and answering our questions.
Thank you.
Appreciate it.